Hi there, I'm Laurie Bartell. I'm an emergency room nurse. I've been a nurse for 13 years and I spent the last 10 years of my nursing career in the emergency department. And today I'm going to talk to you about abdominal emergencies. This class is designed for nursing residents, and that is those of you that have just graduated from nursing school and are coming into the ER for the very first time. So what I'm going to show you is some kind of quick assessment tips. We'll go through some case studies as well. I'm going to try to teach you a few tools that you can use using your nursing assessment. So what we're going to talk about today are abdominal emergencies, quick tips for the resident RNs. Couple the learning outcomes. By the end of this course, residents completing this course will be able to analyze and assess abdominal emergencies. We'll be able to differentiate and anticipate abnormal findings in patients experiencing abdominal emergencies. So when you talk about assessment, what are the things that you're going to need? It's very, very simple. All you really need is your brain, your hands, and a stethoscope. And the stethoscope doesn't have to be expensive. It can just be something that as long as you can hear, it's fine. I've seen nurses use disposable stethoscopes and do just fine. So some quick tips for assessing. Make sure your patients are in gowns. And it's very difficult to assess your patient when they're in tight clothing and lots of layers, and you really can't get a good visual and hands-on assessment when your patient is all covered up. So make sure that your patient's in a gown. The other thing is you need to listen to your patient. Let your patient tell the story, but by no means is it a one-way conversation. You're going to have to ask some questions. Your patient may leave out some information that they might not think is pertinent, but is very crucial to your assessment. You're also going to need to use your hands. I heard once someone said, make sure or never trust a practitioner that's afraid to touch you. So make sure that you use your hands, touch them. It conveys caring, but it also allows you to get some good assessment findings. And then finally, always think worst case scenario. Where we're working in an emergency room, up to 30% of complaints can be abdominal pain related. So make sure you're thinking, if I don't do this exact thing right now, this intervention right now, what's the worst case thing that could happen to the patient? Hey, I'm here with Amanda, my patient. She's come in with abdominal pain. I've already assessed her medication, her medical history, her surgical history, and gone over all those things with her. We've gotten urine to see if she's pregnant or not, because any female, obviously of childbearing age, pretty much anybody with a uterus under 60, you're going to want to get a urine and rule out pregnancy, because that can always pertain to abdominal emergencies. So I'll just show you some hands-on technique. Okay. Well, hi Amanda, I'm Laurie. I'm going to be your nurse.
Hi Laurie.
All right, what's going on today?
I'm just having bad stomach pain since yesterday. It's getting worse.
Okay. And can you show me where it hurts?
Right here.
Right there?
Mm-hmm.
Okay. And it's been going on since yesterday?
Yes.
What else is going on with it?
Vomiting started. I've been nauseous for a few days.
Okay.
The pain's been off and on, but it just got worse yesterday and even more in the middle of the night.
Okay. And what prompted you to finally come in today?
It just got to where I couldn't sleep. So
okay.
It's keeping me up. It's at the point where I just can't stand it.
Okay. And what are you vomiting up?
I'm able to eat, but
okay.
I just, I eat because I'm nauseated, so now it just feels like it's food.
Okay.
I'm throwing up.
Okay. And then any diarrhea?
No diarrhea.
Okay. Any painful urination?
Mm-mm.
No vaginal discharge?
No.
Okay. All right. Good. All right. So anything make it worse? Anything make it better?
When I walk around, sometimes it's worse. So
okay.
if I lay still, it's a little bit easier.
Okay.
On pain. It's just like the sharp movements. If I get up too fast, it hurts.
Okay, and you said it's sharp. Is it always sharp?
When I'm moving off and on, it's dull, and then when I move or any kind of like extra movement, it gets sharp.
Okay, and you told the triage nurse your pain is 8 out of 10. Is it 8 right now?
Yes, ma'am.
Okay, and the pain it's always there, but then the
off and
sharpness
on, yeah.
comes back.
Yeah.
Okay, well if it's okay, I want to take a look at your belly,
Okay.
I'm just going to pull this down and bring your gown up. And Amanda said, show me your pain areas again. Okay. I always ask my patients to show me where they're hurting, because patients, unlike us, don't sometimes have a really good grasp on anatomy. So they'll say their stomach hurts and they'll point to their chest, they'll point to their pelvic area. So this is a big, wide landscape. So I always ask them to show you where it hurts. I'm visually inspecting her belly and making sure that I don't see any abnormalities and it looks fine. And then I'm going to listen, and we would listen to all 4 quadrants, paying particular attention to where her pain is. And then the last thing you're going to do is palpate. And I always want to palpate away from the pain first. So I'm going to go in the opposite quadrant. And patients that are having severe pain are going to be guarding. They may not even let you touch. But when you hit that spot, that's really when they may even just come off that bed. So you don't want to try to hurt them, but you do need to assess where they're hurting and push hard enough so that you can get a good idea of what they're hurting. Now that you've seen a hands-on assessment, we're going to get started and do some review. So if you're ready, we're going to go through a few case studies. I want you to be thinking about what you want to know, what kind of questions you're going to ask the patient, and what is the worst case scenario for this patient. Our first case study, this is a 40-year-old female. The triage nurse has placed this patient into your room, and she's complaining of right upper quadrant pain with nausea and vomiting. Her vital signs are 148/86, heart rate of 92, respiratory rate of 22, sats are 100% on room air, temperature is 99.2, and she's complaining of 9 out of 10 pain. So we're going to have you pause the video to discuss your assessment questions. You wanted to know the patient's medical and surgical history. She had none. You wanted to know if she was allergic to anything. It's just sulfa. Her other symptoms is that she's vomited 5 times. She's had no diarrhea. She said the pain feels sharp and it radiates to her right shoulder. She last ate a half pepperoni pizza about 2 hours before the pain started. So we've got to pick out what are the key findings, what's important with this patient. Key findings are in this patient that we suspect is cholecystitis is the fact that she's 40 and she's female. They say fat, 40, and female, those are all kind of a quick little thing that you can help remember for cholecystitis. Those patients are at increased risk for developing it. The fact that she's having pain in her right upper quadrant near where the gallbladder is. Also the fact that she's having right shoulder pain, and this is called Kerr sign, and you'll see this because sometimes the pain can irritate the phrenic nerve, and that causes pain up into the right shoulder. Doesn't necessarily always happen with all gallbladder type pains, but it can be associated with any sort of abdominal pain that irritates near that nerve. You'll see it also with the blood in the peritoneum as well. And also what's important is when and what food she ate. She last ate a fatty meal just a couple hours before her symptoms started. That's classic for cholecystitis. And the fact that she was vomiting. And so you found out all of this before the doctor got involved, but the doctor has ordered, typically they're going to order urinalysis, CBC, chemistry, sono. We also want to make sure that she's not pregnant. Anybody, like I said earlier, with a uterus, you're going to want to rule out pregnancy. We'll do a sono or ultrasound to diagnose this. We're going to give her some IV fluids to replace her hydration, give her pain and nausea medications, and of course do a surgery consult. All right, our second one. Triage nurse places this patient in your room. She's a 60-year-old female. She's had abdominal pain for 5 days. Her vital signs are 136/72, heart rate is 105, respiratory rate is 20, sats are 96%, temperature is 99.6, and her pain is 8 out of 10. We're going to pause the video now to discuss your assessment questions. All right, for our second case study, what you wanted to know the patient's medical and surgical history. She's got high blood pressure, she's diabetic, she's had her gallbladder removed, and she's also had a hysterectomy. She's not allergic to anything. She's had vomiting and anorexia just means she hasn't been eating. Constipation, pain has been intermittent, and it's worse in the last 12 hours. Your bonus assessment findings for this patient are that you discovered that she had hypoactive bowel sounds. Her last bowel movement was 2 days ago, and she's passing no gas. What are the key findings? Key findings for this patient is prior abdominal surgeries. We suspect this patient may be having a small bowel obstruction. With small bowel obstruction, you often see it in patients that have had prior abdominal surgeries, which can create multiple adhesions and problems with the small bowel. Her age is also a factor. You'll often see small bowel obstructions with older patients. You're going to have decreased bowel sounds. Also, the constipation and the fact that she's not passing any gas leads us to believe that there's a kind of a kink and things aren't getting through. So your diagnostics and the things that the physician are going to order: urinalysis, CBC, chemistry, CT of the abdomen and pelvis with contrast. We want to see everything as the contrast is going through. And IV fluids, pain, nausea medications, and an NG tube. NG tube is often the more conservative treatment for this type of problem, because it helps with that suction. Sometimes it can help unkink that bowel. If that doesn't work, typically these patients will require surgery. So just to review, you need a few things: brain, hands, and stethoscope. You'll need to make sure that you ask plenty of questions. It's not a one-way conversation, it goes both ways. Let the patient tell a story, you ask them questions back. Assess your patient, touch your patient, and always think, what's the worst case scenario? The end. I hope you enjoyed this presentation. Thanks for listening.